Hi, Mike Gibson, Michelle Donahue, coming to you live from AHA 2022, and I think one of the most exciting presentations and new findings here at AHA, the Ocean Dose Study looking at a new inhibitor of Lp(a). And you know, as a person who has elevated Lp(a), people don't know that they have an Lp(a) problem, right? I mean, it's really, we haven't tested that many people. 20% of the population has an elevated Lp(a), right?
Yeah. I mean, there's a tremendous amount of enthusiasm for the idea that we're developing a therapeutic in this space, but just like you're saying, people are not actually measuring it.
What is it, like 0.3% of the people have been tested? I mean, it's a
very
very
small number, and yet people buy into the science. I think that there's a strong body of evidence to support that Lp(a) does play a causal role, but it's a risk factor that, up until now, we haven't really known what to do with the results.
Mm-hmm.
And I think that that's been part of the hesitation for measuring Lp(a) routinely is, if you find out your Lp(a) is high, how do you mitigate that risk?
Statins don't work. Exercise doesn't work. PCSK9 inhibitors may lower it, what, maybe 20%, 30%, something like that.
Mm-hmm.
But now that if we do have something that works, I hope that'll drive awareness.
Well, I think no question. If ultimately the phase 3 programs show that lowering Lp(a) translates into lower risk of cardiovascular events, I think it will become a routine part of practice to measure Lp(a).
So we know it's related to outcomes. The next step is, does altering it improve outcomes? So you've taken the first step, did some dose finding here. Talk to us a little bit about the program.
Yeah, so these are the phase 2 results. The drug is called olpasiran. So this is a novel therapeutic that works.
I think I can pronounce that. Thank God there's a new drug I can pronounce, yes.
I try to keep coming up with tougher ones each time for you.
Okay, thank you.
But it's a drug that works through RNA interference. So within the hepatocyte, what it does is it basically leads to degradation of the mRNA transcript of apo(a), and that's a key component of lipoprotein (a). So by degrading it, essentially it prevents assembly of Lp(a), and it leads to a drop in its concentration.
And what kind of dose range did you study?
So there were 3 doses that were being dosed every 12 weeks. It's a subcutaneous injection. There was an exploratory 4th dose that was every 24 weeks. So it's nice that it's pretty infrequent dosing, and it was a placebo-controlled trial.
And what was the winner in terms of the most effectiveness? Was it that 24-week dosing or 12-week dosing, high dose?
The 12-week dosing looks preferred. So, what we saw with the 24-week dosing was that there was a little bit more oscillation. So at the nadir, you saw that the Lp(a) suppression just was attenuated slightly. The 12-week dose really led to a very marked and sustained reduction in Lp(a). So the doses that were 75 milligrams or higher basically led to more than a 95% suppression in Lp(a) concentration.
95%. Wow, that's amazing.
Yeah, it really almost shuts it down completely. It's really remarkable.
And you know what I've read, and correct me if I'm wrong and educate me, you can get your LDL down quite low with a lot of other strategies. But what you're measuring, the remnant of the LDL that you're measuring is actually kind of Lp(a), right? I mean, it's an LDL variant surrounded by this chain of molecules. So, you think you're doing okay, but you may not be.
Yeah. No, and this is part of the challenge, too, is that people have debated also with these Lp(a) lowering drugs. If you see a little bit of a change in LDL cholesterol, is that really just a reflection of Lp(a) lowering? Because to your point, that the two are intertwined.
Are really intertwined. And have we looked backwards at some of the trials? I've heard that when you look back at Odyssey and some others, that a lot of the benefit of the PCSK9 inhibitors were in people who actually had an elevated Lp(a) once you did your homework and looked at it.
Yeah, this was something that we looked at in Fourier, for example, with evolocumab, and it did suggest that people who had higher levels of Lp(a) at baseline were at higher risk of coronary events. That wasn't a surprise. But they also appeared to derive perhaps greater benefit from being treated with a PCSK9 inhibitor. The interaction term was borderline, but not surprisingly, there was also a larger absolute risk reduction for individuals who had those higher levels of Lp(a).
Can I ask you a question?
Yeah.
Is that because you were lowering the native LDL without the Lp(a), or was it because the PCSK9 was lowering the Lp(a) itself, or do we know?
We don't truly know.
I see.
And I say that because there have been a lot of attempts to do analyses where we try to disentangle, so to
It's
speak,
very hard to disentangle those
how
two.
much is related to Lp(a) lowering, how much is related to LDL cholesterol lowering. I think that really pushes us towards the phase 3 trials for
Right.
the direct Lp(a) lowering drugs, because ultimately that's where we'll get the better sense of the shape of that relationship. Lowering Lp(a) by X amount translates into this much of a reduction in cardiovascular events.
So speaking of phase 3, you're doing that right now. When do you think you're going to be done? How many patients? What kind of endpoints? Can you tell us?
So we're just about to launch the phase 3 program for this drug, olpasiran. So it's going to be starting in December 2022. And we expect that, right now it's targeted for completion at the end of 2026. It's important to make sure that you've got long enough follow-up, that if it takes some time for the drug to have effect, as we've seen with lipid-lowering therapies, you want to make sure you're following patients for enough time to see that benefit.
Now, as someone who has an elevated Lp(a), my question is there a chance, we could have the drug approved before 2026 and then wait on the big outcomes we don't know.
Interesting question, right? I mean,
Yeah.
because this has happened for, the diabetes
Right.
therapies, for
Right.
instance. If you've got a reliable surrogate,
Right.
sometimes people go and try to get approval. So,
Is this a reliable enough surrogate yet?
well, I think that's really the question, right? We know that the other compound, pelacarsen, is already in phase 3 testing. If that trial proves to yield a positive result, at that point, I think that certainly it would validate the Lp(a) hypothesis, and I think that an argument could be made for
That it's a
perhaps,
legitimate surrogate,
but
approvable surrogate.
of course, I sit not with my regulator hat, so I
Yes, no, I understand. And I know I'm asking to speculate, but that's what we do. Great. Well, Michelle, thanks for joining us. This has been fascinating. And thanks to all of you for joining us here live from AHA 2022.